Hi guys, looking forward to seeing you all in a couple weeks or whenever you're coming to the course. And the purpose of these short videos that I'm making for you is to make it an easier transition when you're here in my office on using the type of instrumentation and products that we use. And this actually was recommended by one of my attendees. So this is what we're doing. So the very first thing I want to go over with some of you is how to use two key burrs first. And that's it. I really try to simplify everything that we do as surgeons. So we're only going to use two surgical burrs that are key in taking teeth out atraumatically. So the first one, you can see it on the screen right now. This is a Rasner diamond burr. I learned this clinical gem, one of the best surgical gems I've ever heard, from Dennis Tarnow about 12 years ago. And this, you can see the burr number on the screen right now. And this is how, the reason I like to use this is you can see how thin it is. I just don't know of another burr on the market that works like this and doesn't injure adjacent bone or teeth that you don't want to injure. And the purpose of this is to make a trough that you'll hear me talk about so much. When I say trough, you know, whatever you want to call it, a trench, so that you're going to make that on the mesial, on the distal and the mesial of the tooth we're trying to take out. And I'm going to demonstrate how to use it, you know, right now. But I do want to offer to you and say, you can't buy one or two of these diamonds, and I think they're pretty expensive. You got to have like at least a dozen because they'll burn up really quickly. You'll see it. The diamond will turn to brown, and I don't know why. Sometimes they last through a whole extraction, and sometimes you'll need 3 or 4 into taking one tooth out. But once you use these, especially in the aesthetic zone where taking care of the adjacent anatomy is so important, you know, I don't know how you want to do any extractions without it. So let's pretend for a minute that, you know, we're in the operatory and we're in the office on Monday and a tooth comes in like this. And let's pretend for the sake of the story that there's adjacent teeth and you don't want to hit these adjacent teeth. So how do we get this tooth out? Well, number one, I will tell you, I would probably cut this tooth to start down closer to the gingiva because it'll allow me to sink this diamond in deeper, because the incisal edge right now as it is, let's show you, will stop that. So if I leave the tooth as it is, I can't go further than that. So what you do is you cut this off to start with. And by the way, you'll learn in the course that we use safe throat packs all the time. So I have very nice, easy to use, disposable, obviously, throat packs that you'll put in so that a tooth fragment doesn't go flying down their throat and you have a laryngospasm and they start choking and all that. So now that we have lost, you know, 8 millimeters of our tooth, we can go down further. And this is what you want to do. You want to go down. I am hugging. It's a very common question I get. I am hugging this root. I'm literally pushing this way. And I'm going palatal and buccal. Palatal and buccal. And you do the same thing on the distal. Notice that I sink the burr pretty much to its full depth. Go back and forth. And I do the same thing on the distal. Again, we have to imagine that there's teeth adjacent to this. But that's how you use this diamond. So now we have a trench on the mesial and the distal. Okay? By the way, you can see, even this demonstration, I destroyed this burr. That's exactly what happens. And so in a real live clinical case, I would abandon this burr the second I don't think it's cutting, the second I think it looks brown. This cuts, as they say, like butter. It moves very quickly. And remember, those of you that have not taken a lot of teeth out might not know this, but you never go through the buccal wall or the palatal wall. Never. When you cut interproximal bone, which is on the mesial and the distal, that grows back. But if you violate and come through the buccal or the palatal, you can grow back with a membrane, but it's unnecessary work that you need. So what you'll see me do is, as I approach the buccal, watch the head of my drill will turn this way as I'm drilling to try to protect any chance of going through the buccal wall. Again, I turn my drill as I come towards the buccal, toward the buccal, so I don't come straight and accidentally perf that. It really isn't something that's hard to master. So don't let that scare you in any way. Okay, and if we were doing a posterior tooth, there's no need to use this diamond, and you're about to meet the second surgical burr that we use. And this is, I believe, an SS white, which should be somewhere on the screen. It's got a curved, rounded end. And I wouldn't use this in the aesthetic zone because even though it doesn't look very big, it's probably twice as thick as the diamond we just used and will have the capacity to injure adjacent bone, and we don't want to do that. So but I do use this in the posterior. So let's pretend we were taking this tooth out. Well, and for the sake of this demo, let's assume there are adjacent teeth that we don't want to touch. And I always teach and go into every extraction for you to handle it as if we're going to put an implant there, whether we are or not. So how would I handle this? Well, the very first thing I do with posterior teeth is that if there's adjacent teeth to this, I open up the contacts. So that's the very first thing I do, because you're not going to be able to trough this if you're up against the next tooth. So just literally, you don't even have to use this to open up the contacts. I don't know what you guys have. I have an old burr block of sterile burrs that I don't use anymore for cutting for preps of diamonds that I use. And that's a pretty common burr for me to use to open up contacts. So we would just open up this tooth so I could clearly see down the tooth to the cervical portion of the tooth. And then for sure, I would cut this tooth off at the gingival margin. And I just broke the burr, which happens in the clinic as well. She probably gave me one surgical burr, so I'm just going to have to fake it. Now, by the way, it is very common for me to cut 3/4 of the crown off like you see, and then take an elevator that you would use to take the tooth out, and I flick off the top of the clinical crown like that. And that's literally what I'm looking at. Now, why do I do that? Why would I? And I know a lot of you love to skip. Listen, if you go in to take a lower tooth out and you put a pair of forceps on it like we were taught in dental school, and you rock it back and forth, yeah, you'll get the tooth out eventually, probably, or it'll break, one or the other. But that's not an atraumatic extraction, and that's what you've signed up for here. Atraumatic extraction means we get the tooth out, And we leave 5 walls of bone around that tooth: the buccal, the lingual, the mesial, the distal, and the floor. And then you can graft that very predictably and put an implant in it. So there's reasons why I'm teaching you this and going through it this way. And so, no, we don't want to use a forceps on a tooth because it has a very good possibility of knocking out the buccal wall, as you know. You know that already. So when I'm back on a tooth like this, what would I do? At this point, I would go to that second surgical burr from SS White that I pointed out to you, and I would section this tooth in half. Follow me on this. This is important. I would use the burr and section this tooth in half. And I'd make sure by looking at the x-ray, I would make sure that I have completely severed the tooth. Then I would trough. Remember, when I say the word trough, I mean a trench. Far down into this. I broke my burr, so I don't have another one handy. But the point I'm making to you is that, well, I'm going to use another burr for demonstration purposes. This is important to point out to you. What I want to point out is when you're in there troughing, you're not going in just a little bit. You're going very far down that root, as far as you can go. Okay, and it'll be a little uncomfortable the first time you do it. And you're literally feeling the burr against the tooth. And what you're doing is you're taking away the interproximal bone. And then I go on the other side of the root, because remember I've severed it. And then I go to the distal side of the distal root. And then I go to the distal side of the distal root. So picture this. Watch what I have now. I've cut the tooth down to the gingival margin. I've created a mesial trough, an interproximal trough, and a distal trough. And I know you may be saying right now, oh my God, this sounds like a lot of work. Why don't I just use the forceps? You know why you're not using the forceps. We just talked about that. Because we want to take this. Listen, if you break the buccal bone, you're into a flap. You're into another half an hour using membranes and other things. Why would you put yourself in that situation? So why not try? And let me tell you something. Once you start doing this, it doesn't seem arduous. It doesn't seem like a lot of work. It seems pretty predictable. So once it's in there, what do I do? Once I have it sectioned, once I have a trough on the mesial and the distal, what do I do? Okay. Then what I want you to do is you should own a set of Luxators. There are all kinds of instruments on the market. I have zero financial interest in any of these companies. So what you hear me telling you is because it's the most efficient thing to use. So having a good set of Luxators that come in sets of 4, basically there is a thin and a wide straight. So let me show you those. I think you can see the difference. So these are straight. And they have the same set that are curved. And the curved action gives you a little more torque. So what do I use? What do I put in here? What I like to put in there is the largest elevator I can get into the space. This is a key point for you. If you master this point I'm showing you right now, I'm going to save you a lot of aggravation. Okay, so let's review real quick. It's worth doing it. You came in, this tooth was adjacent to 2 other teeth. You didn't want to touch the other 2 teeth. So by the way, if it had a crown on it, it's very common, right guys? Let's say it had the hardest one you can think of. It had a crown and it had a root canal, and it's a large individual with big roots. And you're freaking out. You're thinking, how am I getting this out? Every approach is the same almost. You take the crown off first. So I just use an old diamond. You guys know how to do this. I zip it up like a sardine can, up the buccal, across the occlusal, down the lingual, and I use an elevator and pop off the crown. That's what I do first. If it was a regular natural tooth, I open up the context, mesial and distal, totally open them up so the tooth now looks like a rectangle sticking out. Because I don't want to damage the tooth in the mesial or the distal. Okay. Then I cut the tooth down right to the gingival margin, which seems counterintuitive, doesn't it? Because what are you going to put a forceps on? Well, we're not using forceps until it's so loose that it doesn't matter what we get it out with. Okay. Then I section a lower molar like a hemisection. And then I trough the mesial of the mesial root, the distal of the mesial root, the mesial of the distal portion, and the distal. So now I have 1, 2, 3 troughs. I insert an elevator, the largest one I can find, as deep as I can go. If you can only go in, like, this is obviously is a model. If you can only go in this far, you didn't trough enough. I'm telling you right now. You should be able to put this elevator in 5 or 6 or more millimeters. And then this is the magic. You turn and hold for 10 seconds. Turn and hold for 10 seconds. If it doesn't move at all, it means you didn't trough enough. You have to trust me on the trough. There is nothing down there that you're going to injure or hurt with a drill. I've never done it. You're not going to do it. So if you stick the elevator in and it won't go in at all, you didn't create enough space. I will say, remember, I don't want you violating anything that's to the mesial of this tooth. It's okay if you take the interproximal bone just adjacent to the mesial root. You can do that. But you got to respect the bone on the distal of the next tooth. And I do this every day. It's doable. It's easy, actually. So you put an elevator, and it may not be an elevator like this. Whatever you get in there, you push, and you push hard apically, and you turn away from the buccal, and you hold that. And that's the hard thing to do. Because what I see a lot of you do in the course is you do this. You jerk it. I don't know why. It's just like a natural movement, but don't do that. Turn it and hold so you feel pressure. And here's what's going to happen. The tooth is going to start to move. And you're going to send me a Christmas card. Okay? You're going to turn it, and its phenomena is called creep, C-R-E-E-P. And it takes advantage of the physics of a root and a periodontal ligament. If you put pressure on it, and bone too, bone is bendable. And when you put pressure like that, it's probably happened to you before and you don't even know it. Do you remember having trouble with a tooth and you're trying to get it out with forceps? You didn't use this method. And you tried and you got so frustrated that you left the room and you came back and all of a sudden the tooth was looser. That's why. It's exactly the same phenomena. So you do that. You get the mesial root out. Now you can see the distal root, by the way. That's why I take the mesial root out first. And then you do the same approach on the distal of the distal root. And sometimes, by the way, you'll see that you miss some bone on the mesial of the distal root. On the front of because now the mesial root's not there, so you can see directly in. Okay? So that's how you take teeth out, basically. Obviously, there's a lot of caveats that you have to learn. You know, what if they break? Well, then we're going to go back to if the root is broken in the socket, generally I'll go back to a diamond like I used in the front of the mouth. Because, as you know, the roots are very thin, and I create a trough around whatever is left, whatever bone is left. And then I go in with an elevator again. I can tell you this, it's a pretty predictable approach. So again, the whole takeaway from this short video is cutting teeth down, especially long-rooted teeth, so that you can then insert your Brasler diamond further because you're not stopped by the incisal edge of the tooth, creating a trough, mesial, distal, respecting the buccal bone, respecting the palate or lingual bone, meaning don't go through it, and respecting the adjacent bone. And it's just practice. I mean, it's hard to mess it up if you're mindful of it. It really is. So the purpose of today was, and one more takeaway, is whatever elevator that you're using, whether it's the one in my hand, or there's even micro elevators that I'll introduce you to for root tips, you must be able to insert it not just at the crestal 2 millimeters, because then you'll just break the root more. You insert it into the trough that you just created, and you push with apical pressure. You hold for 10 seconds as you push the root either to the lingual or the palate, if it's a maxillary tooth, and you hold it. And if you do that for 10 seconds and it's not moving at all, I always have this saying I want you to remember. The tooth will tell you what to do. What's that mean? For example, if you guys tried to take a tooth out with a forceps and it breaks, it was telling you, you need to section me to get me out. And if you put this elevator in and you don't get any movement, you're not troughed enough. It just all makes sense. It's telling you, trough me more. So I try to keep this simple for you, but it works for me. So that's the rules, and that's the end of lesson 1.